Hi student. Hello, good evening to all of you. So I hope I am audible clearly. Just I'll wait for your feedback whether I am audible or visible to you or not. Just give me a thumbs up. Good evening. I am audible, Dr. Karthi. I am audible. Right. Great. So good evening to all of you. So we are basically going to discuss the questions that has been asked in recent JIPMER examination. Right. Thank you so much. Thank you so much. I have started, dear. I have started. Right. Okay. So in my analysis, this time I will say that the JIPMER question, physiology, I will say that it is little easier compared to the last year or last to last year. Okay, little easier, right? So we'll discuss this question, and related to the question some extra point we will discuss so that it will give benefit to our future examination. Otherwise the exam has been done, whether you know the answer or not, it will not affect the exam which has been done already, but it should, you should gain something for your future examination. That is our purpose, right? So all of you again welcome. So first question I am keeping in front of you. Okay, hi, hello everybody. Now try to answer this question. Very simple question, very basic question, right? The resting membrane potential of cardiac muscle. So I hope all of you will be able to answer correctly here, right? So go on, Dr. Pratik, very good. Okay, Dr. Avinash, Nitish, very good. Subhasmita, very Sudeksa, right? Karthi, Ananna, right, very good. You said this so many times. Yes, I know. Right, D. Okay. So I told you this is so many times that please remember this is cardiac muscle. Myocardium they are asking about. If the question is about myocardium, then my answer is D, that is minus 90 millivolt. Minus 70, this is the RMP for neuron only. This is the RMP for neuron. So please remember that here the question is about the RMP of myocardium. Okay, cardiac muscle. So your answer will be minus 90 millivolt. Neuron is minus 70 millivolt. That is, it is given here C. And please remember minus 50, minus 40. These are the RMP of minus 50 is the RMP of the nodal tissue, SA node of the heart. And you know this SA node and AV node, please remember these two things. SA node and AV node, they have an RMP within a range of minus 60 to minus 40 millivolts. Some of the books is saying minus 65, so minus 60 or minus 65 to minus 40 millivolt. This is the range of RMP in both the nodal tissue, SA node and AV node. But I told you repeatedly that if the question is only about the SA node and they are asking about a single number, then your answer will be minus 50 millivolt. And regarding the AV node, this is minus 60 millivolt. So this is true for, this is important for NEET type of examination. They give you answer rather than range, they give you answer a single based answer. So SA node minus 50, AV node minus 60, and neuron minus 70 millivolt already told. And this is not only about the myocardium, also remember the skeletal muscle also has the same RMP. So skeletal muscle also has the same RMP, that is the minus 90 millivolts. So please don't forget this information. Very simple question, but skeletal muscle, myocardium, both of them are minus 90 millivolt. And what about the smooth muscle? All of you know the smooth muscle is like that of the nodal tissue. Smooth muscle is like that of the nodal tissue, minus 60 to minus 40 millivolt. So this is the thing that I have to remember for my future examination, right? All of you. So there should not be any confusion, any controversy. So this is minus 90, D is the answer. Now coming to the next question. Okay, see, next question. Try to answer this question again. Right, I'll wait for a few minutes for your response, then we will discuss. Very good, Dr. Nitish, Avinash, Susmita, right? Okay, Pratik, very good, excellent. So see, I told you that this time JIPMER question is little easier, but what I feel in this question is that you must have to remember something about this cal binding. You must have to remember something about this cal binding, because this will be an important protein in your future examination. So here is my answer. All of you are correct that tropomyosin is the answer. Tropomyosin is not for the binding of calcium, but they are responsible for inhibition of attachment between actin and myosin. So tropomyosin, we know it's a filamentous protein which prevent the interaction between actin and myosin. Okay, so forget about that. Now troponin, this is the calcium binding protein. We know that this calcium binding protein is present in case of cardiac muscle also. This is present in cardiac muscle also, as well as the skeletal muscle also. Okay, right. And this calmodulin, this is the calcium binding protein in case of smooth muscle, right? Remember, both of them binds with 4 molecule of calcium. Both of them binds with 4 molecule of calcium, right? Now what about this cal binding? Remember this, yes, troponin. See, troponin has many fragments. I am not going into detail of that because that's a topic which you all know or you should know. Okay, now this cal binding, remember, this is a protein which is present inside the cytoplasm of many cells, particularly at the level of exactly GIT and at the level of distal tubules of nephron. And this is the protein which is responsible for, I should not say responsible for, which is helpful for calcium absorption. Okay, now just look at the little discussion about this cal binding protein. Suppose this is my GIT epithelium cell. Okay, you will understand this very well. So suppose this is my GI epithelium cell and this is from the luminal side, right? So we know that from the luminal side there will be absorption of calcium. So absorption of this calcium from the luminal side occurs through a channel. Okay, this channel you may not remember the name. Okay, this is a calcium channel which is known as the TRPV5. That is the transient receptor potential channel type V5. Okay, so this type of transient receptor potential channel you must have heard in case of pain perception. Okay, TRP channel is also responsible for pain perception. But now the scientists found out that the calcium absorption from the lumen of the GIT into the cell cytoplasm occurring through this channel, which is TRPV5. Now even if you forget about the channel, remember that whenever calcium enter within this cell, right, you require some calcium binding protein inside this cell compartment, so I'm drawing this calcium binding protein here. So this is my cal binding protein, this is my cal binding protein, right? What it is doing, it is responsible for binding of free calcium which is present inside the cytoplasm. So what it will do, it is basically buffering the free calcium. So remember the word, the question will be asked in future like this, it's a calcium buffer protein. What it is doing, if the calcium is more inside the cytoplasm, it will try to decrease the free calcium level by binding with it. So this calcium will be attached with here. Whenever it is attached, what will happen to the free calcium level? The free calcium level within the cell will be less, because now it is attached with the cal binding. Now if the free calcium level is less, what it will help, how it will help? It will help for absorption of more calcium from lumen inside the cell. Because remember, this is a channel, so channel means through the channel calcium absorption is occurring. So obviously this is a kind of passive transport from high concentration to the low concentration. So from high to low concentration transport is going on. I must have to keep this intracellular calcium lower, otherwise the calcium absorption from lumen will not occur. And this lowering of free calcium inside the cytoplasm is done by this protein cal binding. Please remember. Now after the binding with this, what it will do? Now this calcium cal binding protein will act as a boat, will act as a ferry boat. That means it will now transport this calcium to the other side of the cell membrane, and then it will release here again. Because ultimately, what is your target? ultimately this calcium has to enter into your blood capillary, because that is the absorption into the blood capillary. So when the calcium is going out of the cell, you require a transporter protein, and this transporter protein is sodium calcium exchanger. So this is NCX, sodium calcium exchanger. I hope you must have heard this name, because this is also present in cardiac muscle cell, NCX protein. So what the NCX protein is doing, it is throwing calcium out of the cell, and this calcium will enter into the blood, and the sodium is entering into the cell, right? So this is the NCX protein, right? So basolateral surface calcium absorption is done by NCX, but luminal surface calcium absorption is done by TRPV5, as well as also Dr. Samrik, you have deleted TRPV6 is also there, right? But please remember that this is TRPV5 main, and here this is NCX main, although there is also an active transporter, that is calcium ATPase pump is also there, calcium ATPase pump is also there. But more you go into detail, then it become more complex. But simplified version you have to remember, from the lumen to the cell along the concentration gradient, it is a channel. Then the calcium, which is a free calcium, binds with the cal binding. Then the cal binding is acting like a ferry boat, it is bringing the calcium to the basolateral surface, and from the basolateral surface NCX transporter protein is absorbing the calcium into the blood. This is the exact same mechanism, not only at the level of GIT but also at the level of kidney, that is the distal tubule DCT and upper part of the thick ascending limb of leukophile, right? So this is the mechanism of calcium absorption. You all know that at the level of GIT also vitamin D increases the calcium absorption, right? So if I ask you, what is the role of vitamin D here? It stimulate which step for this absorption process? 3 steps: from lumen to cell, then binding with cal binding, then movement to the basolateral surface, and from the basolateral surface NCX protein is there. I am asking you, vitamin D increases which step of this calcium absorption? Okay, good, go on Santanu, go on. Okay, so vitamin D increases all the 3 steps. So it stimulate the TRPV channel also, it stimulate synthesis of cal binding protein. Okay, cal binding protein also increases, and number 3, that is also stimulate the NCX protein. Means all 3 steps are enhances by vitamin D3. But if your question that what is the main one, then your answer will be main one is this cal binding. Main one is the cal binding. Remember this, place important. And you also know that PTH hormone, parathyroid hormone, they also enhances the calcium absorption. PTH, that is at the level of distal tubule. What is the function of this PTH? PTH stimulate or enhances this TRPV channel. The book will write down that they increases the open probability of this channel, means the channel will remain open for more time, and they also put some more channel on the membrane, but their main action is on TRPV channel. Getting my point? Everything clear? So vitamin D3, it can enhances all of the 3 steps, but if it is, you have to mark only one, then cal binding protein is the main one. But if it is parathyroid hormone acting on distal tubule for calcium absorption, then your answer will be main step is the TRPV channel enhancement. Okay, increases open probability. That's why cal binding protein was previously known as vitamin D stimulated protein, but now they have given a separate name to this protein. Okay, because apart from this vitamin D stimulation, it has also other role. Okay, and that is the function of cal binding here. Everybody got this thing? Just give me a nod whether you understood all of this or not. Okay, important, I'm telling you, this is important for your NEET exam also. This has been given in all of the recent textbook. Okay, understood now? right? Okay, very good, Dr. Harshita. Nilasis, thank you. Now I am going to the next question, right? So here my answer is tropomyosin. Next question, motor unit consists of. This is one of the topic which is one of my favorite. I always teach this motor unit in my classes. Okay, so what is the definition of motor unit? All of you will be answered correctly, I hope, right? Very good, answer this, right? Exactly, good, very good, Dr. Saab, very good, Dr. Kiran, Dr. Ankit. I am not taking name of everybody. Excellent, very good. So this is A and A. Very simple question. So only one thing you have to remember, that is the extra point, that suppose one motor nerve and all the muscle fibers supplied by. Very good. That is the correct definition of motor unit, and this is the definition we generally ask in MBBS examination. Okay, so always remember, if this is your cross section of the spinal cord, then you know from the anterior horn cell region there are motor neuron, and this motor neuron will be divided into multiple parts. So these are the axon terminal. Suppose these are 3 axon terminal here. This 3 means it will supply 3 muscle fiber. So combination of this black color motor neuron, which I have drawn here, plus these 3 muscle fiber, skeletal muscle fiber, which is supplied by it, this will behave like a single motor unit. This is nothing but a single motor unit, right? Suppose I am drawing another motor unit here. Okay, so this is the same location, but the cell body is a larger one. Okay, cell body is a larger one. So larger one means it will be divided into multiple parts. So okay, so suppose this is 4 division. So 4 division means it will supply 4 skeletal muscle fiber, and combination of this 4 skeletal muscle fiber with this motor neuron is again another motor unit. So this is another motor unit. So sometimes this motor unit is defined like that: innervation ratio. What is innervation ratio? One nerve is supplying how many skeletal muscle fiber? That is the innervation ratio. So basically the motor unit definition is in a different term, that innervation ratio. Okay, innervation ratio, right? If I ask you what is the innervation ratio here, this is 1:3 is the innervation ratio. If I ask you what is the innervation ratio here, this is 1:4 innervation ratio, right? Now motor end plate is different. Motor end plate is the area which is present on the skeletal muscle fiber, where this axon terminal is making a junction, neuromuscular junction. So this axon terminal is making a junction here. This junction part where the neuromuscular junction is occurring, that is the area of the skeletal muscle membrane which is known as the motor end plate. So this will be the motor end plate here, okay, at the level of neuromuscular junction. Okay, now I was trying to discuss different thing is that if the question is smallest size motor unit is present in which muscle in your body, smallest size means innervation ratio is very 1:3 to 6. So question is this: smallest size motor unit, typical NEET type of question. Smallest size motor unit is present in which muscle in your body? Which muscle? Could you answer? Remember, here the one motor neuron supply only 3 to 6 skeletal muscle fiber. This is the size of motor unit. Look at very small motor unit, very small motor unit. Now small motor unit is required whenever some fine contraction, fine adjustment is required. Because if the motor unit size is large, you can imagine, if the motor unit size is large means whenever there is contraction, there will be contraction of huge muscle fiber, and that is only for the coarse contraction. Yes, exactly, you are very correct. That is the muscles which are present in the ciliary body of the eye. Okay, so it is present inside the eye, that is the ciliary body and iris muscle, ciliary body muscle, as well as it is also present, sorry, this is not ciliary body, this is present in the extraocular muscles. Sorry, I am extremely sorry, extraocular muscles, right, eye, as well as small muscles of fingers, okay. So these are the area, extraocular muscles of the eye, right? You are absolutely correct, okay. Nilasis has given answer, Dr. Anjali has given answer, extraocular muscles of the eye, okay, and the small muscles of finger. Here I am writing. So for this writing you require very fine adjustment, okay. This fine adjustment is controlled by the small muscles of the fingers or hands, and their motor unit size is smallest, right? So whenever I am asking about the smallest, obviously NEET PG is ready to ask that largest size motor unit is where? Largest size. So here the innervation ratio will be 1:6,000 to 2,000, 600 to 2,000, 1:600 to 2,000. Okay, I'm coming there, Dr. Avinash, okay. Avinash always asked difficult question, right? So remember, yes, so here this is not the blood vessel. Blood vessel is a smooth muscle. Now motor unit is defined for the skeletal muscle. Motor unit is for the skeletal muscle, but blood vessel is the smooth muscle. Na? So question is not there of blood vessel. So here exactly muscles on the back, which is responsible for maintenance of posture, okay. So you require only coarse adjustment. You don't require fine adjustment of the back muscle, okay. If you are dancing something, okay, you require, but they do not require. As well as exactly the gastrocnemius muscle, okay, gastrocnemius muscle of the leg, that is also the large motor unit. This is the largest motor unit, muscles of the back and gastrocnemius muscles, right? Now all of you know, okay, so now coming to this Avinash question. Now all of you know that this motor neuron, they will be controlled by the brain. So the upper motor neuron is coming here, okay. So this is your upper motor neuron, which is coming from the level of the cerebral cortex, and it is controlling this lower motor neuron or this alpha motor neuron or this motor neuron, right? Okay. Now question, if I stimulate this upper motor neuron, or if the cerebral cortex is stimulated, which motor unit will be activated first? Suppose, look at the example. Suppose I want to contract this arm, right? There are multiple motor unit inside the skeletal muscle, from the smallest size to the largest size, okay. I am asking, when the brain is activating this muscle, suppose biceps muscle, brain is activating, which motor unit will be activated first? Your always answer will be, first you try to activate the lean and thin one, because they are fatigue resistance. So smallest size motor unit will be activated first, right? Suppose you want to do some job, okay, you have a huge obese person and one lean and thin person. Whom will you prefer to give the job first? Always the lean and thin person, because he is active, he can do your job. But suppose he is not able to do the job, okay, what will you do? You will recruit more and more, and that is exactly the same principle which occurs in our body. The smallest size motor unit will be activated first. So this is known as recruitment. This is known as recruitment principle. Recruitment always occurs in case of smallest motor unit, okay, and last recruitment occur in case of largest motor unit. So smallest motor unit will be activated first, and largest motor unit will be recruited or activated at the last, right? Why body is doing so? Body is doing so because first you activate the smallest one, see whether your job is done or not. Suppose I want to lift this pen only, why to activate the large motor unit? If the smallest motor unit is doing the job, then do it. But if the force is not able to lift this pen, then I will recruit the side by motor unit if it is larger one, then more larger motor unit, like this. This is the principle. And during de-recruitment, okay, de-recruitment, okay, now your job is done. De-recruitment, your job is done. Now you have to release the motor unit. You want to give the rest. Whom will you prefer to give rest first? The largest one, okay. Otherwise you will get fatigue easily, okay. Otherwise you will get fatigue easily. So largest is de-recruited first, followed by smallest is the de-recruited at the last. This principle, obviously I have not discovered this, I have not discovered this. This is discovered by some scientist who is known as exactly Henneman. That's why this is known as Henneman's size principle. This is known as Henneman's size principle. Remember this. So recruited first is de-recruited last. Recruited first is de-recruited last. This is the principle which is given in book Henneman's size principle. Based on the size, the motor unit recruitment is graded in our body. Okay, so Henneman's size principle: recruited first, de-recruited last. Right? That's the thing which you have to remember. Okay, so that's why I told you this is the topic which I get very interested when I teach this topic in classes. This is one of the favorite, and there are many things which are related to this topic. Okay, I'll take subsequent class only. The fibrillation, the fasciculation, all of this concept are related to this motor unit only. Right? Okay, so okay, now I'm coming to the next question. So again, this is easy question. I told you this time the question is easy. Okay, try to answer. Single muscle fiber, more than one? No, it's not required. Single muscle fiber, more than one nerve, that is not the motor unit. Motor unit by definition, one motor neuron and the skeletal muscle fiber supplied by it. Okay, now here, right, so try to answer A, B, C, D. B, BP decreases due to decrease in cardiac output. So your concept is that pharmacology has taught you that if you give AC inhibitor, your cardiac output decreases first. What is the concept? Okay, yes, it is the question of ACE inhibitor. Okay, you have given ACE inhibitor. Okay, so obviously your BP will decrease. So option between A and B, answer will be A and A. Option will be A and A. Right, peripheral resistance decreases. Exactly, Dr. Zamani Arvind. Okay, you have given the exact reason. So see, whenever the person is taking low sodium diet, right, his extracellular fluid volume will be less and his blood pressure will be reduced. Even if it is for 8 days only. Guyton is saying within 4 days the changes start to occur. So if the person is taking low sodium diet, what will happen? There will be decrease in extracellular fluid volume, okay, and there will be decrease in blood pressure. Right, now here one thing I want to discuss. Rather than low sodium diet, if the person is taking low water, in that cases the same scenario will occur. Always remember, theoretically, extracellular fluid volume will also reduce if the person is taking low water. But rather than water, sodium is more important substances for your extracellular fluid volume regulation. Question is why sodium is more important than only free water. If you take huge amount of sodium, you know what will happen? Okay, exactly, you have also given correct answer, Dr. Avinash. Okay, so if you are taking sodium, huge amount of sodium, and if you are taking only water, huge amount of water, between these two, who is going to rise your blood pressure more? Always answer is sodium. Why? Guyton is giving two reasons. Increased sodium will increases the osmolality of your blood. So increased sodium means it will increases the osmolality. This increased osmolality will stimulate your thirst center. Okay, so there will be increase in thirst as well as increased osmolality also increases the ADH hormone. Now this ADH and thirst, both of them will increases the water content of your blood, and because of this water content there will be increase in the extracellular fluid volume as well as there will be increase in blood pressure. Right, that's why I told you that whenever the person is taking low sodium diet for 8 days, then what will happen? The thing is that there will be decrease in extracellular fluid volume and there will be decrease in blood pressure. But if the kidney of the person is functioning properly, then Guyton is saying that even if the low sodium intake is 1/10 of the normal, the blood pressure is not going to be affected in long run. In long run, the blood pressure is not going to change, because this is the thing which is going to happen within these few days, within the initial days, within 8 days or within 10 days like this. But within months, because kidney is responsible for long term controlling of your blood pressure, and there was a recent question that the gain of the kidney is how much? The gain of kidney is infinity, right? Guyton is clearly writing this. The gain of kidney for blood pressure control is infinity. That means whenever your ECF volume is decreased, whenever your BP is decreased, what the kidney will try to do? Kidney will try to correct this thing, and absolutely there will be normalization of blood pressure without any problem in long run. Okay, that is clearly written in Guyton. But here we are thinking of the acute effect. So the person has taken low sodium diet, there was a steady state blood pressure. Now the person is taking low sodium diet for 8 days. What will happen? There will be decrease in ECF volume, there will be decrease in blood pressure. How the body will counteract this decreased blood volume, decreased ECF in acute cases? Okay, kidney has started their action, but it will take some time. But before the action of kidney, how the acutely this low blood pressure, low extracellular fluid volume will be managed? Look at the flow chart given in Guyton. Okay, so because of the decrease in ECF volume, I told you, okay, because of the decrease in ECF volume, there is decrease in arterial pressure, right? So there will be increased renin secretion at the level of kidney. All of you know this, okay, that because of the decreased arterial pressure, there are JG cell, okay, and JG cell contain intrarenal baroreceptor, which will sense the low blood pressure. Whenever the blood pressure is low, this JG cell baroreceptor will be activated. It will degranulate. Degranulate means there will be secretion of renin. Okay, and what will do renin? All of you know this thing, that next step, that renin is going to convert this angiotensinogen 1. So renin is going to convert this angiotensinogen to angiotensinogen 1, and then this angiotensinogen 1 will be converted to angiotensinogen 2, and this is the enzyme which is angiotensin converting enzyme, or this is ACE. It is written here, it is present in the lung, also it is present in the kidney and vasculature, right? So this ACE inhibitor, whenever the angiotensin converting enzyme, whenever it is converting the angiotensin 2, look at what is happening. It is causing vasoconstriction. It is very, very powerful vasoconstrictor, very powerful vasoconstrictor. So if there is vasoconstriction, what will happen? Vasoconstriction means it will causes constriction of the arterioles also, means arterioles will be constricted, as well as it will also causes constriction of the veins also, right? So if there is constriction of the vein, suppose your vein is there, now you are compressing the vein, what is going to happen? There will be increase in venous return, because you are compressing the vein. Where the blood will go? The blood has to come to the right atrium. Okay, that means venous return is increased. Venous return increase means what will happen? The cardiac output will tend to be rise, and cardiac output tend to be rise means it is try to increase your blood pressure. But rather than this effect, the more effect is that because of the constriction of this arteriole, there will be increase in total peripheral resistance, which is also known as the systemic vascular resistance. Because of the systemic vascular resistance increment, what will happen? There will be increase in blood pressure. All of you know that blood pressure is the product of cardiac output multiplied by your total peripheral resistance. So whenever your total peripheral resistance is increased, there will be increase in blood pressure also. So this is the mechanism what is happening in the body when the person is taking low sodium diet for few days. Okay, and that's why this vasoconstriction mediated by angiotensin, this is under the heading of intermediate regulation of blood pressure control. Angiotensin regulate your blood pressure by this mechanism, which is not the short-term control mechanism, which is not the long-term control mechanism. It is the intermediate control system for blood pressure regulation according to Guyton. right? Now look at here. Apart from this vasoconstriction, angiotensin 2 also causes renal salt and water retention by production of aldosterone hormone. But this action will take long time, so this is slow action. But the quick action is this vasoconstriction. So this is happening in your body, and by this mechanism body is trying to increase your blood pressure because your blood pressure is already low. Now you got the thing that in this scenario, if you block this enzyme, by giving ACE inhibitor, what is going to happen? Okay, this thing I told you again and again, whenever you are giving ACE inhibitor, what will happen? So ACE inhibitor means, look at this, important for future question, means there will be decreased production of angiotensin 2, right? So it will causes a venodilation also, right? A venodilation also, and it will causes arteriole dilation also, arterioles dilation also, right? Because of the venodilation, what will happen? There will be decrease in preload. Remember this for future examination. I told you venoconstriction means what is happening? Venoconstriction means increase in venous return. Increase in venous return means, if I ask you what will happen to your end diastolic volume, end diastolic volume increases. What is the end diastolic volume? End diastolic volume is nothing but your preload. Now if you do venodilation, there will be venous stasis of blood, venous pooling of blood. Venous pooling blood of means less blood will return to heart. That means decrease in preload, decrease in end diastolic volume. And arteriole dilation means what will happen? Arterioles are the site of total peripheral resistance. That's why there will be decrease in TPR. Now because of this decreased TPR, because of this decreased preload, okay, what will happen? Your blood pressure will decrease, and TPR is one of the determinant of afterload, right? So please remember this thing. That's why we say that ACE inhibitor is given in the patient of congestive cardiac heart failure. It is going to reduce which one? Preload or afterload or both? Your answer will be ACE inhibitor decreases both your preload, both your afterload. That's why in this question your answer is A, and A. Now you tell me whether you got this thing or not. Give me a thumbs up whether you understood this or not. Okay, both preload, afterload, both. So ACE inhibitor decreases both preload, afterload, both. Okay, that's why you know na that if you give the digitalis, that increases the contractility without changing the preload. Okay, if you give diuretics, what will happen? Which portion you decrease? Diuretics, you are decreasing the blood volume. Diuretic will decreases your preload. It will not affect your afterload. It will not affect your contractility. If you give purely dioxin, that will only increases your contractility without affecting the preload, afterload. But ACE inhibitor, it is acting both, decreasing the preload also, decreasing the afterload also. Okay, and that's why it is given. So here the answer is decreased blood pressure due to decrease in total peripheral resistance, right? Very good. Thank you so much for giving thumbs up to me. Now next question. Now this is the question a little difficult, but again I have taught you, I have teach this thing in classes with detailed mechanism, that how hypoxia causes pulmonary vasoconstriction. So now they are asking what is the mechanism behind this vasoconstriction during hypoxia. Tell me, what is your answer? So look at the option. Okay, look at the option. This is purely based on recall. Some of the students are saying that rather than systemic artery, everything was a pulmonary artery, but I believe this is more correct. Okay, so tell me, what is that? Systemic arteries have which type of channel? Systemic arteries have which type of channel? So hypoxia causes vasodilation and systemic artery, unlike vasoconstriction in pulmonary artery, right? Calcium dependent potassium channel, when okay, I'll change this D into calcium dependent potassium channel. Okay, no problem. Okay, but again your answer is which one? A. Are they asking the pulmonary circulation? Here the option is systemic arteries have. Systemic arteries have B. ATP sensitive potassium channel. Systemic arteries have ATP sensitive potassium channel, and this oxygen sensitive potassium channel, this is present in the pulmonary vasculature. This is present in the pulmonary vasculature, right? This is present in pulmonary vasculature, right? So remember, pulmonary vasculature, that is oxygen sensitive potassium channel. All of the systemic vasculature, ATP sensitive potassium channel. Now obviously question is arising in your mind that how this is happening, sir. So suppose this is pulmonary vasculature, right? Pulmonary vasculature. This is the smooth muscles of pulmonary vasculature. Where these channels are located? Every channels, all of these channels, they are located at the level of the smooth muscle cells only. Smooth muscle cells only, because vasoconstriction, vasodilation means that is the property of the smooth muscle. Smooth muscle contraction has to occur for the vasoconstriction. So this is the smooth muscle cell of the pulmonary vasculature. What type of channel is there? Oxygen sensitive potassium channel is there, and this channel is open normally. Difference. So what I am saying, what is the channel here? I already told you that here the channel is O2 sensitive potassium channel, right? O2 sensitive potassium channel is there. It is open when the oxygen tension is normal. So that's why I have written here that it is open normally. Resting condition, it is open. It is different with the systemic vasculature. I am coming there. But whenever there is hypoxia, okay, whenever there is hypoxia at the level of this cell, what is going to happen? This channel is going to be closed. The channel is going to be closed. So I am writing here that hypoxia leads to closure of the channel, right? So closure of the channel means I can understand now what will happen, sir, that the potassium which was leaking through this channel in resting condition, okay, potassium was leaking from the channel in resting condition. Now this channel is closed. Now this channel is closed. So what will happen? This potassium will not be able to leak out of the cell. So there will be some extra potassium stay back inside the cell. Extra potassium staying back inside the cell means what kind of charge will be there inside this cell? Positive charge. Positive charge means this is nothing but depolarization of the smooth muscle cells. This depolarization will open up another channel, that is voltage dependent calcium channel. That is voltage dependent calcium channel, CA.V, voltage dependent. Why I am stressing the word voltage dependent again and again? Because if this voltage is not depolarizing, then the channel will not open. So whenever there is depolarization, the channel is opening. That's why it depends on voltage. What kind of voltage? Positive voltage. So calcium will enter inside this cell. Now whenever the calcium is entering inside the cell, what is going to happen? Okay, calcium entry will leads to contraction of this smooth muscle, and contraction of this smooth muscle means what will happen? There will be vasoconstriction. So this is the mechanism, vasoconstriction. This is the mechanism how hypoxic pulmonary vasoconstriction occurs. Getting my point? This is the mechanism how hypoxic pulmonary vasoconstriction occurs. Now you must have read about one pathophysiology of high altitude pathophysiology, which is known as the high altitude pulmonary edema, HAP. You must have heard high altitude pulmonary edema. What is that? That is nothing but pulmonary edema due to this vasoconstriction. So basic pathology of this condition is edema due to pulmonary vasoconstriction. Because the patchy vasoconstriction will be there. Patchy vasoconstriction means what will happen? Whenever there is vasoconstriction, some other places blood flow will be with very huge force. Pulmonary vasoconstriction will be patchy. So if there is patchy vasoconstriction in some region, there will be blood flow through other region. So what will happen to the blood flow through the other region? Increase velocity. that increased velocity will damage the endothelium cells of pulmonary vessels, and that will leads to permeability, increased permeability, and that will leads to pulmonary edema. That's a separate class. I will take a session on that. But remember that high altitude pulmonary edema, the treatment, one of the treatment of this condition is calcium channel blocker, nifedipine. Now could you understand why we use nifedipine or calcium channel blocker to counteract this high altitude pulmonary edema? Could you understand now this? That the pathophysiology of this vasoconstriction. So vasoconstriction is doing the main culprit. Vasoconstriction is the main culprit here. I cannot block this oxygen sensitive potassium channel because I do not have any drug like that, but I can simply block this calcium channel which is present here, and that's why we use the nifedipine, that is the calcium channel blocker, for one of the treatment of this high altitude pulmonary edema. Got this thing? Give me a thumbs up whether you understood this basic mechanism or not. Okay, got this? Student, give me a thumbs up. Right? Understood? Systemic nifedipine, I told you. Nifedipine. Okay. Now systemic vasculature. Now coming to the systemic vasculature. Okay, although oxygen therapy is there, okay, oxygen therapy is used for every cases, okay, and for the acclimatization you also use the acetazolamide. I am not asking that. I am looking at the main treatment of this, okay, and nifedipine is used there, okay. Now coming to the systemic vasculature. Systemic vasculature, suppose this is the smooth muscle of the systemic vasculature. Now again there is the potassium channel, okay, but this potassium channel is ATP sensitive potassium channel. Now second difference is that not only the sensitivity of the channel is different, but also the channel normally remain closed in resting condition. Normally the channel is closed in resting condition, right? Closed in resting condition. So potassium is not able to going out of this cell because the channel is closed in resting condition. Now whenever there is hypoxia, okay, there will be less amount of ATP inside the cell, okay. Because of the less amount of OTP, what will happen? This channel will open up. So I am giving positive here. Positive means it will leads to opening up of the channel, opening up of the channel. Now whenever the channel is open up, I can understand that the potassium will start leaking from the cell. So if extra potassium is leaking out of the cell, normally there is a balance. Potassium is not going out of the cell because the channel is closed in resting condition. Now we have opened up the channel. Open up channel means extra potassium is losing out of the cell because of this decreased ATP. So what will happen? There will be negativity inside the cell. This negativity means we know this is nothing but hyperpolarization of the smooth muscle cells. Hyperpolarization means there is no action potential is going to happen on this smooth muscle cell. So action potential is not occurring means contraction will not occur. So what will happen? There will be dilation, okay, or there will be relaxation of this smooth muscle. Because of the relaxation of the smooth muscle, there will be systemic vasodilation. There will be systemic vasodilation. That's why we know hypoxia causes systemic vasodilation, okay, and hypoxia causes pulmonary vasoconstriction, right? So this is the mechanism. Neurophysiology in app special class, it is reminder. Neurophysiology, that is a basal ganglia cerebellum you are talking about, that is only remaining, okay. So basal ganglia cerebellum, generally I assume that anatomy should teach you better way, okay. Anyways, I'll take, no problem, okay, but you tell me whether you understood this thing or not, okay. But please remember, this is one of the main reason how the systemic vasodilation occur. Also remember another thing, this is not related to this channel, but hypoxia also causes this smooth muscle will not be able to maintain its tone because of the hypoxia. So I am writing another thing, that apart from this channel mechanism that we have described here, apart from this, also remember smooth muscle lost their tone. So I am writing here loss of tone of smooth muscle is another reason which happens during hypoxia, because if there is no hypoxia, the maintenance of partial contracted state of the muscle is also lost. That is known as the loss of tone of the smooth muscle. So if there is loss of tone, there will be again vasodilation. So this is the second cause for this vasodilation. Okay, this is the first cause, this is the second cause, right? So this is the whole thing that you have to remember. So that's why I told you here your answer will be that systemic arteries have ATP sensitive potassium channel, but pulmonary arteries have oxygen sensitive potassium channel, right? So this is the MCQ. Now coming to the next question. Now this question, I told you again and again that Pappage circuit, sometimes it gives in examination and it is purely based on memory. It is purely based on memory. Could you answer? Could you recall? Okay, purely based on memory, because there is no big concept here. It is memory. Okay, you have to remember what are the nucleus present in Pappage circuit, and it is purely memory based question. So here is the anterior thalamic nucleus, right? So look at this. This is the circuit that I have given in my book, and I have told you in lecture also that it starts from here, that hippocampus, then through the fornix it is connected with the mammillary body through the mammallo-hypothalamic tract it is connected with the anterior nucleus of thalamus. So this is your MCQ. Then anterior nucleus of thalamus, okay, it connected with the cingulate gyrus. Okay. Niemann's neurophysiology. Okay, I'll plan something. Okay, I'll plan something. Sure. Now it is connected with the cingulate gyrus. Cingulate gyrus is connected with the parahippocampal gyrus, and parahippocampal is connected with the enterorenal cortex, and then again back to the hippocampus. So this circuit is known as the Pappage circuit. But I told you, please remember what are the functions of these different nucleus. So hippocampus, all of you know that this is the area which is responsible for, all of you know this, short term to long term memory conversion. So hippocampus main function is this one. Mammillary body and anterior thalamic nucleus, please remember, this is responsible for recent memory. Okay, so short term memory conversion also plus short term memory processing is done at the level of hippocampus. Mammillary body and anterior thalamic nucleus, these two are responsible for recent memory. Now all of you know that Pappage circuit is for your emotion, for your cognitive function, right? So this cingulate gyrus is the main one which is responsible for your cognition as well as your emotion part, right? Although this intact connection is required, but this is the main part. Along with that, cingulate gyrus is also responsible for controlling of your blood pressure as well as your heart rate. Control of your blood pressure, control of your heart rate is also done by this cingulate gyrus. Coming to this enterorenal and parahippocampal gyrus, these are the area which is responsible for spatial memory. Remember, discovery of this spatial memory by this enterorenal and parahippocampal gyrus gives Nobel Prize. Okay, discovery of this brain area is responsible for spatial memory of space, memory of three-dimensional space. You can understand which is the roof, which is the floor. You can understand what is the map, okay, in which direction map is going. That is the spatial memory. Spatial memory is mainly by this enterorenal cortex and parahippocampal gyrus, and discovery of this gives Nobel Prize. So please remember this important information, right? So this is about the MCQ. Now coming to the next question. Cell bodies of orexinergic neuron, orexin. Okay, orexin. So this peptide is responsible for the controlling the food. Okay, food control, your feeding behavior, anorexigenic substances and orexigenic substances. But here they are asking that orexin is produced by which nucleus of your central nervous system, which region of your central nervous system. Exactly. So this is the line which is directly taken from Guyton. Okay, lateral hypothalamus produces orexin, right? So please remember orexin, right, produced from lateral hypothalamus, and this orexin is projected in different area of the brain, okay, but particularly, exactly, very good, Dr. Avinash, you recall everything. Locus coeruleus is for noradrenaline, raphe nucleus is for serotonin, very good. So orexin projected to various region of the brain, but mainly you have to remember it project at the level of brainstem region, okay, at the level of brainstem, and it responsible for controlling your sleep, okay, controlling the sleep, right? How? If the orexin level is high, if the orexin level is high, then what will happen? The person will remain awake, okay, wakefulness. And if the orexin level is low, the person will enter into REM sleep stage. The person will enter into REM sleep stage. That's why the genome is writing. The genome is writing that orexin is a molecule which is switching between your wakefulness and your REM sleep stage, right? So orexin is a switching between wakefulness and REM sleep stage, right? This is the thing you have to remember. Now all of you know that orexin acts on their receptor, okay, and if there is mutation of this receptor, or if there is destruction of this orexin producing neuron, then what is the disease? Narcolepsy. All of you know narcolepsy occurs, okay, and all of you know that narcolepsy means what will happen? The person will directly enter into which stage of the sleep? REM sleep stage. That's why you know REM sleep means there will be loss of muscle tone, complete muscle tone will be lost, and that is one of the understanding of the narcolepsy, right? Okay, so this is wakefulness and REM sleep stage, switching between these two because of this orexin, right? This I have taught in classes, okay, I think you recall, Dr. Avinash, okay. Now coming to this, few points I have collected for your purpose, that orexin, also known as hypocretin, right, produced from lateral hypothalamus, responsible for switching between awakening and REM sleep. Orexin provides excitatory input to many brain areas, but main one is the brainstem, you have to remember this, okay. And when active during awakening, so orexin producing neuron are active, means orexin level is high, so person will remain awake, and it stops firing during the REM sleep stage, right? Also, loss of orexin signaling as a result of defective orexin receptor or distraction that I told already, it will produce narcolepsy, right? Apart from that, recent information is coming that orexin also responsible for regulation of your pain. It is also responsible for regulating your memory. We know that it responsible for food and fluid intake. We know this thing, but new information is coming about this, but still not known how it is working. But this is the thing you have to remember, okay. So now this is the another question, easy question, I think, easy question. Now come answer this question. Insulin dependent glucose uptake, tell me the answer. Exactly, right, give everybody answer. Right, so here they are asking basically that insulin independent glucose uptake occurring in which area? That is the kidney, okay. All of you know this thing, this is very simple question. They are basically asking that which GLUT is not dependent on insulin. All of you know that insulin dependent GLUT is GLUT4 and GLUT12, okay. So GLUT4, they are located at the level of myocardium, that is the cardiac muscle, okay, muscles of the heart. Second, it is also located at the level of skeletal muscle, right, skeletal muscle, right, and it is also present at the level of adipose tissue. And GLUT12, it is also insulin dependent GLUT, extra point, but please remember this is present at the level of the heart muscle also, means myocardium, as well as it is also present at the level of prostate. It is also present at the level of prostate. So glucose uptake in all of this region, myocardium, skeletal muscle, adipose tissue, okay, prostate, all of these are dependent on glucose. So independent glucose uptake is done at the level of kidney. All of you know that at the level of kidney it is done by SGLT 2. Okay, main, that is also SGLT1 is also there. So that's why the answer is kidney, right? Okay, again another question, simple question. Damage of pituitary stalk during surgery. A very basic question. I told you this time very, I should say, simple question, easy question in JIPMER, right? Okay, so all of you answer, right? So why prolactin is the answer? Yes, you are absolutely correct. Prolactin is the answer because you know that the lactotrophs cell which producing PRL, right? PRL, it is controlled by prolactin inhibitory factor which is secreted from hypothalamus, right? So this prolactin inhibitory factor is nothing but dopamine, right? Dopamine acting on D2 receptor on this lactotroph of anterior pituitary, and because of this D2 receptor activation, what will happen? Prolactin secretion is under the negative control from hypothalamus, all other hormones are under the positive control from hypothalamus. That's why if you give a cut here, if the pituitary stalk is damaged, here, what is happen? This tonic inhibition by dopamine is lost, and that's why prolactin level will be high, right? So this is in brief the discussion of the prolactin control. Okay, so now this is the last question I have kept as a controversy. I am not asking you for the answer because calories burned while gardening for 1 hour. I don't know gardening means what type of gardening they want to ask you. I also do gardening, but only watering in the plant, that is different. But if you are doing other type of gardening, right, then the calorie expenditure will be more. Generally it is given in medicine website, it is 200 to 400 range, right? That means all of them can be answered. But if you go through the general gardening, right, general gardening means without doing much work, then my answer is 300. But always you can make controversy, always you can argue with me that what is the source here. Okay, I did not get any standard textbook sources for this, although Guyton has given one chart for energy expenditure, Guyton, but again I am not finding out gardening here, right? See here, walking also given, carpentry also given, right? Sawing of wood is also given, but in between I think gardening will be there, it is not given. Okay, so I cannot predict from here, from the Guyton reference, but I searched from article and some other book. Now this is one of the article which is taken from Physiological Review, okay, which is very well known article, very standard article, Physiological Review. Here they have given gardening. Now they have given huge amount of gardening, okay, different study, different age group, everything they have given. But what I can find out here, that on an average they have given 4.4 calorie per minute, okay, and similar type of answer has been given in this book. I have given the reference here, I have searches from internet, okay. So this book is also giving that it is 1.81 calorie per pound body weight per hour. So you can multiply with a 70 kg body weight person, then it will be around 270, 260 like this. So that's why I am saying that here my answer is 300. But always you are free to argue, you are free to make controversy, but I am telling you this is not going to be repeated in future examination, so you can relax here, okay. So this is 300. So this is last for today's question. So now every time I do some promotion, okay. So if you want to join the Unacademy platform, please do use my code, that is DRSOUMEN10, which will give you 10% discount. Now you can find me on, I have a plus batch going on, you can find my plus batch in this link, okay. Then you can also follow me on my Telegram group. Okay, I am also taking free live classes other also, so everything link has been given here. Okay, plus follow the Unacademy YouTube channel, right? So they will give you information about what other free classes are going on there, right? So please follow here, subscribe the YouTube channel here, and this is the upcoming free classes for NEET PG also, and the link for upcoming classes, everything is given here. And if you at any point of time decided to join Unacademy platform, that is the paid platform, okay, this is the way how you have to pay in the system. So this is the procedure, how the payment is done in that system, everything is given here, so you can look at them, right? So this is all about today's class. Thank you very much for joining me. Thank you. Okay, good night, good night, good night. Take care, stay well. Thank you so much.